And here we are, fresh smack dab in the middle of allergy season, and chapter 89, Nursing 103. Let's get this going. Just spent all day getting your clinical times tallied and in, and you have all heard from me by now, so let's do this. All right. Come on. There we go. Urinary disorders. Everybody pees. Well, almost everybody, except those with renal issues. So, urinary tract divided into two sections: the upper tract, which is the kidneys and the ureters, and the lower tract, which is the bladder and the urethra. Ureters and urethra, they're all tubes. It's just location, location, location. So ureters run from kidney to bladder. Urethra runs from bladder to outside. So let's look at a little bit of med term for this. Cysto, pertaining to any bladder, you have a couple in your body. Litho, stone. Nephro, the kidney itself. Pyelo, the region of the kidney, the renal pelvis, which you're picking up in Bio 101. Uretero means the ureter. Urethro, the urethra. Pay attention to the spelling because the spelling itself makes all the difference in what you're talking about. Vesico, now we're looking at specifically the urinary bladder. And then finally, trypsy or crushing. So lithotripsy, stone crushing. We use that when we're dealing with renal calculi or kidney stones. Lab tests. Oddly enough, urinary system, we would be dealing with urinalysis, routine or random. These are for more than just seeing which drug of choice you prefer. These can also tell you the state of your kidneys and your urinary system. Renal function test, BUN, blood urea nitrogen, or BUN. This is a blood test. Serum creatinine, again, blood test, since serum. Creatinine clearance, another blood test, and then uric acid. So these are all blood tests that would be used to see how your urinary system is functioning. So what do you think, true or false? Does it need to be refrigerated? False. So, does it need to be refrigerated? Yes, it does. So, false. Bacteria in the urinalysis may multiply if they're not refrigerated, which can cause some funky readings when you're trying to figure out what is going on, what the type of infection is. Okay. So, imaging. IVP, a pyelogram. So, pyelo, the renal pelvis. All right. So, inject dye intravenously and see how it collects in the renal pelvis. Radioactive renogram, cystogram, and voiding cystourethrogram. Okay, so cysto, we're looking at the bladder. Cystourethro, we're looking at the bladder and the urethra. Okay, so that may involve a radiopaque tracer that is put in so that you can see what the urine flow is like. Retrograde pyelogram. Again, we're looking at the renal pelvis, but in this case, we're coming up from the bladder, from the ureter, and looking backwards up into the renal pelvis. Renal arteriogram, so looking at the arteries in the kidneys, right? A cystoscopy, cysto, bladder, scopy, or using a scope, using direct visualization into the bladder, and then needle biopsies. Right? So taking a needle in to take a sample of a mass discovered through imaging, versus going in and taking out a big section. So this is again where we begin talking about, hey, the scar tissue is absolutely wonderful at being scar tissue. It's actually perfect at being scar tissue. It's not really good at being anything else. So using a needle biopsy, we're taking a very small chunk out, which will be replaced by a very small bit of scar tissue, versus going in and cutting out a big chunk of the kidney and having all of that area being replaced by scar tissue. That makes sense, because scar tissue does not filter. Scar tissue doesn't make urine. Scar tissue is scar tissue. Urodynamics. So we're looking at urine flow, urine movement. So uroflowmetry, residual urine volume. So very often we'll be talking about the post-void residual. How much is left in the bladder after the patient has urinated? Right? Cystometrograms, urethral pressure profiles, seeing how much pressure is actually being added to the urine stream when voiding. And then electromyogram, or testing muscles in the peritoneum to see how they are reacting. Nursing process again. I'm sure you're bored to death of the nursing process by now, but well, it takes over your life. You are nurses, and we are dealing with the nursing process, or you will be nurses, I should say. Don't call yourself nurses yet, you'll get in trouble. Planning and implementation, right? And PI, assessment, nursing diagnosis, plan, implement, evaluate. So these would be looking at general nursing considerations depending on what is going on with the patient. Whether urine retention, maybe we're talking about incontinence, kidney disease. These general nursing considerations will change with the overall condition and then become more specific to each patient. Hence the plan, implement, evaluate, assess, nursing diagnosis, plan, implement, evaluate, back to assessment, continuing on in a never-ending circle. So what do you think? True or false? Minor urologic surgical procedures, we need to do aggressive client and family teaching. Minor procedure, aggressive teaching? Yeah, we do. Because they're on an outpatient basis. So we need our patients, their family members, their significant others, their caregivers to be well trained and very aware of the things they need to look for after these procedures. Okay, how to prep pre-op and what to look for post-op. Careful documentation of teaching and reinforcement of teaching. Every time you are with that patient, if you do not provide some sort of teaching about anything, you have missed a golden opportunity. Urinary incontinence. Here we are, so involuntary voiding or involuntary urine loss. Sometimes it is temporary as a result of a procedure. Sometimes it is the result of long-standing neurological or physical issues. Right? Transient temporary incontinence. There are a couple of different factors that can cause this, but the key here is it is transient. It is not permanent. A true or total incontinence, the patient has absolutely no control over when they lose urine. Stress incontinence brought on by, well, not stress as you might think of nursing school, but physical or muscular stresses. Think, what would be a good one here? So we have a full bladder and an increased intra-abdominal pressure. All right, patient is bearing down, or they're using their abdominal muscles. They're creating pressure on this full bladder, and the sphincters are not enough to hold the urine in. They're not strong enough. There you have the stress incontinence. Reflex or urge incontinence. These may be neurologic in etiology, or overflow incontinence. Something that I'm surprised more nurses don't actually suffer from, and that's when your bladder is so full that you can no longer hold it anymore. Like hour 10 of the 12-hour shift, where you have not had the opportunity to urinate yet. So what do we think? Urinary incontinence that happens when the bladder overfills with urine and is not able to release it is referred to as, is that transient? Is that a true incontinence? A bladder overfills. Stress incontinence, reflex, or overflow. If you said overflow, you were correct. Overflow, the bladder is overfilled, kind of like trying to pour that last little bit of Mountain Dew into your cup. It's, that last little bit, and it spills over the side. So treatment: Crates, Kegels, these are described in your text. Electrical stimulation, yes, there's a pacemaker for that. A pessary, which you will also find well described in your books. Medications to treat undercaffeination. Lost my word there momentarily. So to treat a more transient reflex, that's the word I wanted, reflex incontinence, and surgery to help fix support structures, possibly to open up a clogged ureter that's causing, or a constricted ureter that is, or urethra, I should say, not ureter, that is causing urine retention and then overflow. And augmentation. So cystoplasty, we're talking about the bladder. So doing a surgery that may shrink and augment the available muscle in that bladder. So nursing considerations, depending on what's going on. So in pushing fluids, to remove irritating substances. This may be as a result of infection. It may be as a result of medications and or procedures. Teaching them how to empty their bladder completely. Sorry, it's allergy season. The cottonwood's blowing. I'm trying not to sneeze all over the computer screen. So, and this may be in positioning or pressure applied with the hand. Biofeedback and Kegels to strengthen the pelvic floor and the sphincters. Or teaching the patient or assisting them managing an external catheter, such as a urethral catheter like a Foley catheter, or a suprapubic catheter. UTIs, the old person's friend. So acute cystitis. So cystitis, you have inflammation of the bladder, and acute meaning it's come on suddenly. Chronic cystitis or chronic UTIs, we may see these very often in older patients or patients who suffer from urinary retention, or who are coming in towards end-stage dementia and are not able to care for themselves well. Acute pyelonephritis. All right, this is not a bladder infection. It is still a urinary tract infection, but it's not a bladder infection. Pyelonephritis, we're talking the renal pelvis and the kidney. If you had to have the choice between a bladder infection and pyelonephritis, take the bladder infection, because the inflammation in the pelvis and kidney, especially if it is this next one, chronic pyelonephritis, that inflammation can cause lasting damage to the kidney. And the kidney is very important. They're so important. We have two, right? We're born with this, most of us, majority of people are born with a spare. They are very important organs, and they are also very prone to damage through hypertension, hypotension, and medication effects, or the effects of infection long-term damaging those structures, or the urine backing up due to obstructions in the ureters or the urethra. So signs of infection, right? Dysuria, difficulty or painful urination, having to go frequently. Right? Now think about this, especially those of you who've been working in long-term care with the elderly. Think about this, nocturia. So having to eat up at night, this goes in with the frequency as well, not sleeping through the night because they have to get up and urinate. Right? Cloudy urine, blood in the urine, fever and chills. Okay, these are signs of infection to begin with. Flank pain, pushing more through to the kidneys, right? Getting some inflammation and pain in the kidneys. And perhaps the key, especially in our elderly patients, mental status changes. That may be your first sign that your elderly patient has a urinary tract infection, is mental status or personality changes. Sweet old Ethel has gone from loving grandmotherly type to trying to hit everybody with her cane. That may be a sign that perhaps Ethel has a UTI. So let's look at inflammatory disorders. Interstitial cystitis, IC. So interstitial is the space between the cells, right? Interstitial between the cells. So in this case, it is in between the cells that make up the bladder itself, the bladder wall, that muscle. When you have inflammation, the muscle cannot contract as well because it has all of this extra fluid that is holding it, keeping it from contracting. Right? Glomerulonephritis. I said it. I trip over this word all the time. Glomerulonephritis. Right? You have acute or chronic. This is inflammation of the glomeruli in the kidneys. Those structures that are doing the filtering and the excretion of wastes and water creating urine, the glomeruli, they become inflamed and they become less effective at their job. Chronic glomerulonephritis, we'll see that in renal disease, and may lead to end-stage renal disease. End-stage kind of like it sounds, this is the last step. The kidneys no longer function. And then your patient is faced with a three-pronged choice: transplant, dialysis, or death, because you cannot survive long without kidneys, without their function being replaced. Obstructive disorders, hydronephrosis. Essentially, there's an obstruction, water and urine is backing up into the kidney. This may be an outflow obstruction from the bladder and everything is backing up through the bladder, through the ureters, up to the kidney, or it could be inflammation or an obstruction in the ureter itself, or where it connects to the bladder, that is not allowing flow through and causing fluid to back up in the kidney. Acute, okay, versus chronic. Again, we have the same situation where acute comes on and can be fixed. Chronic is ongoing. Acute may cause some damage, but chronic will cause permanent damage. And then stones, erythrolithiasis. All right. So we have bladder stones. We have ureter or bladder stones, ureter stones, kidney stones. Okay. The difference here is their location. Right? And these are formations of minerals that that clump together and form these little rock-like things. Now, if you've ever seen a kidney stone, you may think, okay, I got a kidney stone, and it looks like this little piece of gravel they just picked up off the edge of the creek, small river, however you pronounce it. They're generally not smooth and easygoing. They tend to be kind of sharp and spiky because, well, that's just how they form, which makes them very often difficult and extremely painful to pass. And pass they must. We can go in and break them up using sound waves and lasers, and often do when they are too large to pass on their own. So with stones, okay, we like to collect some weird things. And one thing that we like to collect from our patients, and we have them strain for it, it's kind of like a little coffee strainer that we give them to urinate through, because we are trying to strain out the stones so that we can see what they are. Right? Patient undergoing stone removal. Now, this is a procedure where they will likely be sedated. And it is an invasive procedure as we are going up through the urethra, through the bladder, through a ureter, and into, if it's in the case of a kidney stone, all the way up into the renal pelvis to break this stone up and allow it to be removed. Client teaching for this, we're going to teach them all the important things. Review this in your book. A little pink tinge to the urine is normal, but frank bleeding is not a good sign. But we're also going to teach them, yes, we want you to strain for the renal calculi, strain for the stones. We need to see what they are, what to report, signs and symptoms for infection. All of these pieces, review it in your book, because you might see it again on a test somewhere in Nursing 103. All right, so urethral or urethral strictures. So these, when you visualize the urethra or the ureters, they are small tubes. Now, generally with a small tube, you pour fluid down it and it flows, and it flows at a constant rate. However, these bands can form around the ureter and cause it to be a much smaller diameter. It goes from, okay, this is really extreme, but down to a smaller diameter, which can impair the flow. All right, interferes with urine passage, can cause urine retention, right? Painful urination. We'll do some, likely do some urodynamic flow testing. Treatment for this down at the bottom of the page. Now, it's not a urethrectomy, because the ectomy, removal of, remember your medical terminology. It's a ureterotomy. They go in and they cut that band, which may or may not be completely effective. Recall that these patients still may develop another stricture due to the formation of scar tissue from the ureterotomy. And then we got tumors. It's a toma, right? Benign renal cysts. Now, note it says benign, not cancerous. Not cancerous, no big deal. Except it could be. Even a benign tumor, a cyst, it may be benign, it may be non-cancerous, but it depends on where it's at, whether or not it's actually causing trouble. So consider you have your urinary bladder, and you have your urethra. You've got a sphincter there, and you develop a cyst or a benign tumor right next to that, which takes up space, distorts the bladder wall, and impairs that sphincter's ability to open up and allow urine out. So even though it's benign, it is still causing another condition, right? Renal cancer. Right? Now, happily, we have two. Renal cancer, if caught early, is not a death sentence, unless it's got both kidneys, and then it's not necessarily a death sentence. But I foresee some dialysis in your future. Bladder tumors, even if they are benign, they can still distort the bladder wall, impairing the bladder's ability to completely contract down and causing the bladder not to fully empty during urination. Right? Some of these treatments, urinary diversions. Right? So you've got your urostomies. Taking the outflow from the bladder from the ureter through the external genitalia and bringing that out to the surface of the skin. Right? Ileal conduit is one, cutaneous ureterostomy, all right, where the ureters are going, instead of bladder and urethra, the ureters are now going straight to the surface of the skin. And then you have your continent diversions, which means the patient has some control as to when it flows, right? And these continent cutaneous or neobladder to urethra, check those out in your text. I'm not going to go too deep into them with this. All right, trauma, lacerations. Okay, so just like we were talking about biopsies for the kidney, okay, we do the small biopsy versus cutting out a section because we have less tissue impacted, less area of scar tissue, more area of functioning kidney. In the case of a kidney laceration, we will have scar tissue and there will be some loss of kidney function. Plus, it's highly vascularized. So highly vascularized, you got a lot of blood flow going there. If it's lacerated, you've got a lot of blood flow now coming out. Right? Bruising of the kidney, yes, they can be bruised. Bladder rupture. This is where I would normally say, okay, so you're taking that long road trip, and you've been pounding Mountain Dew and coffee for the last 100 miles. You really, really got to pee, but you only got 50 miles to go until you get to where you're going. and you just decide to hold it, and your bladder's full to bursting, and you're almost in overflow incontinence. And then the guy pulls out in front of you and stomps on the brakes, and you get into a wreck. And that seatbelt laying across your bladder causes an intense pressure, and your bladder pops. It actually can happen. Bladder rupture is a potential in NVAs. So with bladder rupture, of course, it would need to be repaired. Now with those repairs, then you have a lot of other considerations, like while that's repairing, the patient will have a urinary diversion of some sort because it can't put stress on that repair. And then once it is repaired, once it is functional again, remember that there is scar tissue formation, and the patient may end up with problems fully voiding again because of a band of scar tissue keeping that, because scar tissue, great at being scar tissue, not great at being smooth muscle, which is where your bladder's at. So it does not contract. All right, so we got renal impairment. Right. Kidneys aren't working really well. Renal insufficiency. Okay, they are not meeting the demands put upon them. And then renal failure. Now you can have acute renal failure due to hypotension or due to medication effects. Right? Acute renal failure is correctable. Chronic renal failure, once the damage is done, the damage is done, and it can continue to progress into end-stage renal disease. Which brings us into dialysis. Hemodialysis, peritoneal dialysis. So hemodialysis is what you would think of. Your patient goes to the dialysis clinic 3 or 4 times a week, and their blood is removed, processed, excess fluids, the waste products removed. This is the machine that is replacing your kidney, right? And it is something that can be done at home, but the patient and their caregiver have to meet certain criteria. Not everyone is a candidate for home hemodialysis. And then we have peritoneal dialysis, where this is actually really pretty cool. I had a patient who was on peritoneal dialysis and said it was the greatest thing ever because he could travel. A catheter is placed in the abdomen, and the patient dialyzes overnight. They have a machine, they have bags of dialysate, and the dialysate is pumped into the abdomen, is allowed to sit, and it is drained out through a tube into the sewer system. And it repeats these cycles. And what the peritoneal dialysate does is it draws the waste products and the excess fluid into the dialysate and then pumps it out. Again, not everybody is a candidate for this, but it does allow the patient to have more freedom with their traveling. Because a patient on hemodialysis, if they're going to travel, if they're going to go somewhere, they have to go somewhere with a dialysis clinic, and they have to be able to get into that dialysis clinic, and they have to be able to keep on their schedule, where the patient with peritoneal dialysis can take their dialysate with them or have it delivered to their destination and can dialyze because they dialyze overnight. Shunts, fistulas or graft, AV, arteriovenous, fistula, AV graft. You'll generally see those in the arms. And if your patient has the AV fistula or the AV graft, you do not use that arm for blood pressures or anything else. These are surgical procedures to get these set. They are necessary for the patient to be able to receive dialysis. So you treat that arm as if it is the winning Powerball ticket. And often you will find patients who have been on dialysis for long term. They may have had a graft on the left arm and it went bad from whatever reason. Now they have one on the right arm. And when both of those go bad, then the next place that I have seen very commonly is in the thigh. Otherwise, for more temporary, you have the subclavian or jugular catheters for dialysis. It is very important that you treat those gently as well, because remember that they are going into some pretty big vessels, and if you dislodge that, they're going to bleed a lot and very fast. So what does dialysis replaces the kidney function? Okay, that's really the purpose of dialysis. Removing toxins, removing excess water, balancing the electrolytes, balancing the acid base. Sometimes giving medications, things that would normally be given IV, can be given during the dialysis process. Removing the waste products. You know, all of that except instilling the medications. Hey, that's what's happening in the kidney. It's just a great dirty big artificial kidney. So, true or false? Short of breath, anemic, or chronically fatigued? We would say true. All right. Kidneys, besides their filtering and waste removal, produce erythropoietin, EPO. This triggers the bone marrow to produce red blood cells. If the kidneys are damaged, they're not functioning, they're not producing erythropoietin, which may cause anemia, right? Anemia, not producing red blood cells, not producing sufficient red blood cells. Red blood cell has one job: carry oxygen. If you don't have enough red blood cells, you don't have enough oxygen transport, and you're not getting oxygen to the tissues. So the patient may feel short of breath. The patient will be anemic and chronic fatigue due to hypoxia or hypoxemia. So, dialysis, possible complications, exsanguination, your new favorite word, right? Severe hemorrhage. It is immediately life-threatening. Exsanguinate, all that blood is going out. Septicemia. Right? So, sorry, the cottonwood is really blowing around here. So septicemia, we have systemic bloodstream infections, potential for an air emboli, and it's not like Hollywood shows you. That air bubble in your IV line that's that long will not kill you. It takes quite a bit more air in the vasculature to create an air embolus that can actually kill the patient. That little bubble of air that's in the IV line that your patient freaks out about, or maybe you freak out about, that little bitty bubble will be absorbed into the bloodstream like that. Right? Hemolytic anemia. So the process of dialysis can damage the red blood cell, hemo, and cause them to split, lysis, which then decreases the number of functioning red blood cells. So you have hemolytic anemia. Disequilibrium syndrome, which can be brought on by the dialysis process, and fluid movement across various membranes and from various, and especially across the blood-brain barrier, can cause this disequilibrium syndrome. And then hepatitis, inflammation of the liver. So what do you think? And, so when a graft is, or a shunt is cannulated, when the dialysis process is going on. You think a single clamp attached to the dressing? No. That cannula separation, that's a big needle going into a big vein or a big vessel, and exsanguination can happen. So 2 clamps there to the dressing, close at hand, so you can clip to keep the patient from exsanguinating or bleeding out in front of you. Right. Potential cure for renal failure with some caveats here. All right, it is a potential cure for renal failure, a kidney transplant. Right. You do have to match the recipient and the donor. They have to be closely matched. However, even with near perfect tissue matching, your patient is still going to need to be on anti-rejection drugs, because the immune system recognizes this stranger's kidney as that doesn't belong here, let's attack it. Anti-rejection drugs work to tamp down the immune system, which leaves that patient then at a greater risk for infection of all types of infections. And even with anti-rejection drugs, it can still cause rejection of the transplant can still happen. The complications of the anti-rejection medications, your patient is at huge risk for developing any and all infections that come their way. And that is, unfortunately, with any organ transplant. And that, my lovelies, was a urinary system. So, timesheets. Turn in your timesheets. That's what I was doing all day. And with that, have a great weekend.